Bismillahirrahmanirrahim. Vascular online training, practical summary of the European Journal of Vascular and Endovascular Surgery, July issue 2020. It is a bit difficult for a lot of vascular surgeons to read vascular journal on a regular basis. Although they are very important and they are essential, especially the main two, Journal of Vascular Surgery and European Journal of Vascular and Endovascular Surgery. I will try to convert this difficult task into an easy job. I will try to convert what I call a practical summary. Not every paper that you have to read or get the conclusion. I will summarize what is important and what is of practical value, and I will convert it into a Facebook post that you can listen to over 10 or 15 minutes to summarize the monthly issue. I hope by this way, by changing the format, it will be easier for vascular surgeons to follow the vascular journals. European Journal of Vascular and Endovascular Surgery. In the past, it used to be called European Journal of Vascular Surgery. That is why the name ESVES. There is a mobile application now that you can download a current issue of ESVES. In this issue, it's about 163 pages. Here are the current editor-in-chief. The previous editor-in-chief was Professor Sharif Sultan, but now it is Professor Florian Dick from Switzerland and Martin Björk from Sweden. Here is a printout of the content. These are 4 pages which have all what is in this current issue. Not all of them are important, and will summarize the best 6 papers of them which I think are important. So I will summarize what is clinically relevant for you to know. Now, the first editorial review was titled "The Comparison of Laser Ablation, Foam Sclerotherapy and Surgery Class Trial." This is a review to this famous paper of Class, which was reviewed about 800 patients over 5 years duration between 2008 to 2012. In summary, it showed that the recurrence rate of sclerotherapy was 47% after 5 years, surgery was 54%, and laser was 53%. So recurrence was high, re-intervention rate was also high, 7% in surgery, 11% in laser, and 14% in sclerotherapy. That is why in the NICE guidelines, which mention that C2 and C3 should be managed, either one of these 3 options, this was ignored by many hospitals. And this was the summary of this editorial review by Bruce Harrison from UK. Now, number 2, which I think is important, is a very beautiful article, analysis of the differences between ESVES 2019 guidelines and the NICE 2020 guideline for abdominal aortic aneurysm. The article is excellent. It compares the differences in the guideline of NICE and ESVES. It basically said that strategy was different. The NICE want an economical, valid option for treating EVAR, while ESVES wanted the opportunity for advances of vascular surgery to keep on progressing. So what this paper adds, it's a very nice paragraph. I will read it for you. In this paper, the difference between two recently published guideline diagnosis and management of patients with abdominal aortic aneurysm, NICE Guideline 2020 and European Society ESVES 2018 are reviewed. There is different perspective, cost effectiveness and clinical effectiveness. The methodology, quality assurance process, and evidence are important in explaining the discoordinate recommendation of the two sets of guidelines. While both guidelines have their own merits, the comparison may offer suggestion for further improvement of quality of transparency of ESVS guidelines. So the NICE guideline concentrate on cost, while the ESVS concentrate on effectiveness, and that is why there is a basic difference. Now, this is very nice comparison between what is the difference in management of EVAR in both cases, and I will summarize here the basic difference. The threshold of intervention in women, there was a difference. NICE guideline mentioned to consider if it is more or equal than 5.5, while ESVS at a smaller value. In female, 5 centimeter. And you can see the differences in that schedule, which is very nice. Also, repair of unruptured AAA. There was a difference between these two guidelines. Recommendation in NICE open repair unless contraindicated, and this will lower the cost of EVAR initially, while ESVS EVAR should be considered in patients with reasonable life expectancy. So you can see the difference between the two guidelines. The last one is repair of ruptured AAA. In the NICE guideline, it considered EVAR or open option, while in ESVS it divided complex aortic aneurysm, infrarenal, or complex aortic aneurysm. And each one there is a recommendation suitable for that. So this is very nice schedule to compare the differences and the strategy between two very big guidelines. Number 3 is a very nice article about the diabetes and aneurysm rupture. New evidence muddies the water. We know there was studies to mention that metformin protect the aortic aneurysm from getting bigger and from rupture. It doesn't seem to be the case after multiple meta-analysis. And the summary that the protection role of diabetes or diabetic medication like metformin in progression of AAA was not proven. So at the moment, metformin, we don't have any grade A recommendation when to use it for patients with aortic aneurysm. Number 4, which I think is very important, is the threshold for iliac aneurysm repair, equipoise remain, and good judgment prevail. We have a level A evidence has been published supporting conservative management of men with abdominal aortic aneurysm more than 55 millimeter. For women, the evidence is less clear, but the lower threshold is 5 centimeter in women. For iliac artery aneurysm, the borderline is 35 millimeter, and the incidence of rupture does not depend just on the diameter. It's multifactorial, so there is a window for good judgment when to intervene, and with the higher success of IBD devices in iliac, you can tackle more iliac artery aneurysm less than 3.5 centimeter, and this is what this article showed. So the conclusion of this article, based on the available evidence, the aforementioned ESVES clinical practice guideline management of abdominal aortoiliac artery aneurysm suggests a 35 millimeter diameter threshold, and this was class 2B level of evidence C. The nice paper number 5 is a novel shaggy aorta scoring system to predict embolic complication following thoracic endovascular aneurysm repair. This was a very nice article. He started to document what does we mean by shaggy aorta. He started to classify them into according what is called shaggy score by selecting 3 areas from the cut section of CT angiogram and characterizing a score system for each part, and the shaggy score will depend on how much shaggy aorta or how much atherosclerotic plaque and occlusion you found. And he found a very good correlation between his shaggy score and the embolic complication, but did not, if you have a patient shaggy 3, you know that you have a high complication rate of embolic. There's nothing you can do about it, but at least we have a scoring system of shaggy aorta, and this is a very nice paper number 5. Now the last paper is actually a very strange case, unusual carotid shunt migration. This was very strange case. I would not mention where it has been done, but this was a 64-year-old man, underwent carotid paraganglioma, carotid body tumor resection, neck dissection under general anesthesia, owing the tumor encasement on internal carotid. A shunt, Burbank shunt, was used, and when the tourniquet was loosened, the shunt actually migrated. You can see the shunt into the ascending aortic arch, and patient underwent cardiac surgery for shunt removal. They did not elect to have an endovascular removal of this shunt. Very strange case, but the conclusion that whenever you are using a carotid shunt, please put a clamp on the shunt in order not to lose it for proximal or distal migration. A very strange case, but very nice case to see as well. There was more angiosome paper. Again, nothing to add to our knowledge. Again, there was multiple antiplatelet paper, nothing to add, and a lot of research articles which did not have any practical relevance. This is what I think is important in July issue, and this is a quick summary over 10 minutes. I wish you all a very nice day, and thank you. Dr. Muhammad Omar Al Farouk.